Welcome to the debate. Imagine a surgeon looking at this incredibly detailed, high-resolution image of a patient's lung, right?
Mm-hmm.
The image is, frankly, a marvel of modern medicine. They can see every vessel, every delicate lobe, and sitting right there in the upper quadrant is a distinct golf ball-sized mass. It looks terrifying.
Oh, absolutely terrifying.
Right, but here is the terrifying truth. From that structural image alone, they have absolutely no idea if that mass is just a harmless bundle of scar tissue from an old infection or a highly aggressive, rapidly dividing cancer that could kill the patient in months.
Yeah, it's a chilling scenario, and I think it gets to the absolute core of what we are discussing today. Because, well, when a first-year medical student opens their very first anatomy textbook, they are presented with this comforting expectation of precision, right?
Exactly. The perfect little diagrams.
Right. Every nerve, every bone and vessel is perfectly color-coded. But the moment they step out of the lecture hall and into the clinical reality of a living, breathing human body, that static textbook image just shatters. I mean, they have to start peering inside patients using radiation and magnetism, sound, radioisotopes.
It's a massive paradigm shift. I mean, suddenly, they are staring at a rather murky landscape of grayscales and shadows, and how these students build their foundational mental model of imaging, well, it dictates how they will diagnose patients for the rest of their careers.
For sure, it changes everything.
And that brings us to our core disagreement today. As students navigate this transition, I represent the perspective that imaging must primarily be understood through a structural and anatomical framework. I mean, we have to focus on how physical properties map static structures and tissue densities.
And, I take the opposing view. I argue for a functional and physiological framework. I firmly believe the true power of medical imaging lies in capturing real-time dynamics and metabolic activity. The body is not, it's not a classical marble sculpture, right? It is a highly dynamic, constantly moving organism.
Well, so to set the groundwork for my position here, the structural and anatomical framework is unequivocally the bedrock of medical imaging. Before a first-year student can safely do anything else, they must first understand the physics of density and anatomical resolution.
Okay, but
We are talking about mastering exactly how high-energy photons are attenuated, meaning, blocked or reduced in energy by human tissues, to create a map of the body, or how complex mathematical algorithms can reverse engineer shadows into perfect 3D cross-sections.
Right.
This framework teaches students exactly where pathology exists. Without a rigid, highly resolved structural map, any functional imaging you do is really just floating in a void without context.
Yeah, but prioritizing static anatomy limits a student's clinical intuition right out of the gate. By focusing on modalities that track movement and metabolism, students learn what the body is doing, not just what it looks like.
I mean, they need to know what it looks like first.
Sure, but if you only look at the structure, you are entirely missing the disease process itself. To put it simply, form is meaningless without function.
I see why you think that, but let me give you a different perspective. Let's start with the most fundamental tool we have, right? The one every medical student encounters first, plain radiography, or X-rays.
Okay, the classic X-ray.
The sheer brilliance of an X-ray lies in the physical mechanism of attenuation. It's not just taking a picture, it's an actual physical interaction at the atomic level.
Right, we are essentially shining a flashlight of high-energy photons through the patient.
Precisely. We fire these photons generated from a cathode ray tube through the body, and the tissues absorb or block them based entirely on their physical density. Bone is incredibly dense with calcium, so it attenuates the X-rays the most.
Which makes it white.
Right. It stops the photons from hitting the detector film behind the patient, which is why bones appear bright white on the film. Air in the lungs, on the other hand, is mostly empty space. It attenuates almost nothing, letting photons pass right through to strike the film, causing it to turn dark black.
Sure.
In soft tissues like fat, muscle, and water, they fall into a gradient of grays in between. It is a pure, unadulterated structural map.
It's a map, sure. But, a map only tells you that a road exists. It doesn't tell you if the road is closed or if there's a massive traffic jam.
Well, relying on function first is like trying to read the traffic flow of a city without having a map of the streets. X-rays provide the essential street map. If you are a first-year student trying to figure out why a patient is in agony, you cannot interpret physiological traffic until you know exactly where the physical boundaries of the organs are.
The contrast agents. We literally have the patient swallow barium, which is a heavy metal, to paint the internal walls of the stomach and intestines. Or we inject iodine into the bloodstream to light up the vessels. We physically enforce the structural map.
See, I come at it from a different way. A static street map, no matter how beautifully shaded with barium or iodine, is fundamentally insufficient when a patient's life is on the line. I mean, you're looking at a snapshot from the past. Let's look at ultrasound or sonography. Here, we step entirely away from ionizing radiation. Instead, we use this fascinating physical phenomenon called the piezoelectric effect.
Wait, this is where we use the crystals in the ultrasound probe?
We send these sound waves into the body. When they hit a boundary between different tissues, say the edge of a liver or a kidney, they echo back. The returning sound wave hits the crystal, physically vibrates it again, and converts that vibration back into an electrical signal that the computer reads.
And because sound travels so quickly, the computer can calculate exactly how deep that tissue boundary is based on how long the echo took to return.
Yes! But here is the crucial difference from your X-ray. The computer updates this calculation dozens of times a second. It creates an image in real time.
Okay, real time is nice.
You aren't just looking at a frozen moment. If you hold an ultrasound probe over a patient's chest, you are watching the leaflets of the heart valves snap open and closed at this exact second. You're watching the heart muscle contract. You're literally watching life happen.
Real-time observation is valuable, I won't deny that. But ultrasound has a massive structural blind spot. The sound waves cannot penetrate dense bone, and they scatter wildly in the air.
Well, sure, there are limitations.
If you want to look at a brain inside a dense skull, or lungs filled with air, ultrasound is completely blinded. It lacks the definitive universal clarity of an X-ray-based system.
It makes up for it in physiological insight, though, especially when we elevate the technology to Doppler ultrasound. This is where the functional framework really flexes its muscles. Doppler utilizes the frequency shift of those sound waves.
Like the ambulance siren effect.
Exactly, like the ambulance siren. When an ambulance drives toward you, the sound waves of the siren are compressed, so the pitch sounds higher. As it drives away, the sound waves stretch out, and the pitch drops. Doppler ultrasound does the exact same thing with red blood cells.
Okay, so it tracks the movement.
Right. As sound waves bounce off blood cells, moving toward the probe, the frequency shifts up. If they are moving away, it shifts down. The computer color codes this shift, usually red for flow toward the probe and blue for flow away. So a clinician isn't just seeing a blood vessel, they are calculating the exact velocity and direction of the blood.
Wow, okay.
They can see the chaotic turbulence of a blocked artery. They can see regurgitation, blood flowing backward, in a failing heart valve. That is a live read of the cardiovascular system's physiological state.
I mean, that is a phenomenal tool for fluid dynamics. But when we talk about sophisticated, deeply embedded pathology, we must pivot to the unmatched structural mapping of computed tomography, CT, and magnetic resonance imaging, MRI.
The heavy hitters.
Exactly. If a student is going to understand true three-dimensional anatomy, they have to understand CT. It takes your basic X-ray attenuation and turns it into a mathematical masterpiece.
By spinning the X-ray tube around the patient?
Right. Instead of one flat picture, a CT scanner spins an X-ray tube and a detector around the patient in a 360-degree arc, taking thousands of microscopic snapshots from every conceivable angle. But the real magic isn't the camera, it's the algorithm. The computer takes all these overlapping shadows and performs complex mathematical transformations to reverse engineer them into a 3D block of data. It literally creates a virtual loaf of bread out of the patient's anatomy, which the physician can then slice into infinitesimally thin, highly detailed cross-sections.
If you were looking at the bony cage, trying to identify intricate lung disorders or detecting complex intracranial lesions, CT provides a structural fidelity that ultrasound simply can't touch.
CT gives you brilliant slices of anatomy. I concede that. But it's still just anatomy. It's still relying on tissue density.
Which is exactly why we bring in MRI to map the soft tissues without using any ionizing radiation at all. And the physics of MRI is arguably the most elegant structural tool we possess.
You're talking about proton alignment. Let's unpack that for a first-year student, because it sounds like science fiction. I mean, you are literally using a giant, supercooled magnet to turn the patient's water molecules into tiny compass needles.
That is exactly what is happening. The human body is mostly water, which means we are full of hydrogen protons. Normally, the magnetic axes of these protons are pointing in random directions. But when we slide a patient into an MRI machine, the massive magnetic field forces all those protons to align in the same direction.
Right.
Then we hit them with a specific radio wave pulse. This pulse physically knocks the protons out of alignment.
And when you turn the radio pulse off,
The protons naturally relax or snap back into their original magnetic alignment. As they snap back, they emit their own tiny radio signals, which the machine listens to.
right.
The conceptual brilliance here is waiting. Different tissues take different amounts of time to snap back into alignment. By carefully adjusting the timing of when we send our pulses and when we listen for the echo, we can isolate precise anatomical distinctions.
Like T1 and T2?
Exactly. T1-weighted images will show fat as bright white, while fluid, like cerebrospinal fluid, shows up dark. But if we change the timing to a T2-weighted image, we flip that. Suddenly, the fluid lights up bright white, which is absolutely perfect for spotting edema or inflammation around a structural lesion. This is structural categorization at its absolute peak.
I hear what you're saying about precise boundaries and brilliant categorization, but I have to bring us back to the surgeon looking at that mass in the lung from our opening hook.
Okay.
What does that perfectly categorized, brilliantly lit structure actually tell you about the cellular activity of the mass you just found?
Well, I'm not convinced by that line of reasoning because you can't even begin to treat a tumor or a lesion if you don't know its precise boundaries, which only MRI and CT provide. A surgeon cannot resect a functional state. They can't take a scalpel to a concept. They have to cut along physical, anatomical lines.
But
The surgical margins, the actual physical tissue they remove to save the patient's life, are dictated entirely by the structural map.
I'm sorry, but I just don't buy that. Let me tell you why. Precise anatomical boundaries cannot confirm malignancy. You might use an MRI to find a perfectly mapped, high-resolution mass. The borders are crisp. The structural definition is flawless, but your structural framework cannot tell me if that mass is dead scar tissue or if it is a highly aggressive, rapidly dividing carcinoma that is actively spreading.
They do look similar.
They look nearly identical on your map. This is where nuclear medicine and PET scans, positron emission tomography, become the ultimate arbiter of truth.
By injecting radioactive material directly into the patient.
Exactly. And that is a profound philosophical shift for a medical student. Unlike X-rays or CTs that pass radiation through the body from an external machine, nuclear medicine relies on radiation emitted from within the patient themselves. The patient becomes the light source.
That's a poetic way to put it.
We inject them with radionuclides that emit gamma rays. For PET scans in oncology, we use a very specific functional trick. We inject a radio tracer called fluorodioxyglucose, or FDG.
Which is essentially radioactive sugar.
Yes, it is a glucose analog. Think of it like a Trojan horse. Because cancer cells are rapidly dividing and metabolically hyperactive, they are incredibly hungry. They consume glucose at a vastly accelerated rate compared to normal, healthy tissue.
Okay.
So, we inject this radioactive sugar into the bloodstream. The cancer cells greedily pull the FDG inside themselves, thinking it's food. But they can't metabolize it, so the radioactive material gets trapped inside the tumor. The FDG concentrates in those exact areas of high metabolic activity, emitting positrons that annihilate with electrons, shooting off gamma rays that the scanner detects.
I mean, it is clever.
We aren't looking at the shape of the tumor anymore. We are literally tracking the chemical hunger of the cancer. A dead scar won't light up at all. An active cancer will glow like a beacon. We are definitively tracking the disease process itself.
It is a brilliant physiological trick, utilizing the cancer's own metabolism against it. But I have to point out a crucial limitation. Even in a PET scan, the functional hotspots are almost always overlaid onto a CT scan. We call it a PET-CT. Why?
Well, to give context,
Because without the CT's anatomical framework, your PET scan just gives you a glowing cluster of gamma rays floating in an undefined void. You might know there's a hungry cancer somewhere in the left side of the chest, but without the CT map, you don't know exactly which lymph node or lobe of the lung it's sitting in. You desperately need the structural framework to localize the function.
But it is the functional signal that dictates the actual diagnosis. The CT merely acts as the coordinate grid. It's the graph paper. The actual pathology, the confirmation that this patient has a life-threatening illness, is revealed entirely by the metabolism.
Well, let's push this debate down to the microscopic dimension, because the structural framework holds absolute dominance there as well. When first-year medical students learn histology, they are ultimately studying microscopic architecture. And the pinnacle of this is electron microscopy, or EM. When we need to understand the true fundamental nature of a cellular pathology, we use electromagnets and electron beams to achieve massive structural resolution far beyond what any light microscope can do.
Right, because electrons have a much shorter wavelength than visible light.
Exactly. It allows us to see the actual organelles of a cell. We have transmission electron microscopy, TEM, which fires electrons directly through infinitesimally thin slices of tissue to reveal internal structures down to individual macromolecules. And then we have scanning electron microscopy, SEM, which bombards the surface of a specimen with electrons to create incredibly precise three-dimensional structural representations of the cell exterior. The structural fidelity remains king, even at the nanometer scale.
It provides an impressive geometric model, certainly.
That's an interesting point, though. I would frame it differently. It isn't just a geometric model. It is the physical truth of the cell. Think about the podocytes in the kidney. For a first-year student, these are tiny, intricate, tentacle-like cells that wrap around the capillaries in the kidney to filter your blood. If you look at a healthy kidney on an electron micrograph, those structural tentacles are perfectly spaced. But in certain kidney diseases, you see that structural integrity is compromised. The tentacles are flattened and fused together. The physiological failure of the patient's entire renal filtration system is entirely secondary to that physical structural collapse. If you understand the structure, the functional failure is obvious.
That's a compelling argument, but have you considered how routine light microscopy, the tool medical students spend hundreds of hours using, is fundamentally a functional and chemical assay?
A chemical assay?
Long before a student ever looks at a black and white electron micrograph, they are looking through glass lenses, using photons to magnify tissue sections that have been stained with vibrant colors. And the absolute ubiquitous stain in all of medicine is H&E, hematoxylin and eosine.
Wait, you're claiming a basic pink and blue stain is functional imaging? Oh, come on. We use H&E specifically to color the tissue so we can visually differentiate the physical structures.
I am absolutely claiming it's functional. Think about what those colors actually represent chemically. The coloring is entirely dictated by the functional state of the cell. Hematoxylin is a basic dye. Chemically, it loves to bind to acidic regions. What is the most important acidic region in a cell? The DNA and RNA in the nucleus. So hematoxylin colors the nucleus dark blue. Eosin is an acidic dye that binds to basic regions, like the structural proteins floating in the cytoplasm, coloring them pink.
Right, which gives us a beautiful structural contrast between the nucleus and the cytoplasm. But it's not just contrast, it's a chemical readout. When a pathologist looks at an H&E slide, they are not just seeing physical boundaries. They are literally looking at a painted picture of the chemical environment.
If a cell has gone rogue, if it is rapidly dividing and highly functional, like a cancer cell, it is churning out massive amounts of active nucleic acid.
I see where you're going with this.
Because that heightened functional state, its nucleus will stain fiercely, aggressively dark blue. The functional state, the chemical acidity of the DNA replication, drives the visual output you are seeing on the slide.
But the pathologist is still analyzing the morphological shape of those stained nuclei to determine dysplasia. They are looking to see if the nucleus is misshapen, enlarged, or physically invading neighboring tissues. The structural shape is what ultimately tells them the cell is malignant.
But that shape is driven by the underlying chemistry. The functional framework simply reaches a deeper, more fundamental layer of causality.
Well, if we step back and summarize our positions, I maintain that the structural and anatomical framework is the indispensable foundation for any medical student. Understanding the physical mechanics of attenuation in X-rays, the brilliant mathematical generation of 3D axial slices in CT, and the manipulation of proton spin and relaxation times in MRI, this provides the essential map.
It is a good map, yes.
Without mastering this physical architecture, the medical student has no context. They don't know where a disease occurs, they don't know how a tumor is physically displacing normal anatomy, and they certainly don't know how a surgeon might safely intervene. The structure is the physical stage upon which all biology plays out.
And I maintain that the functional and physiological framework provides the vital narrative of that biology. A physician is at their core a healer of dynamic processes, not a surveyor of static terrain. Understanding how to capture real-time frequency shifts through Doppler ultrasound and utilizing metabolic tracing via PET scans and radioactive glucose, well, it equips the clinician to see the disease actively in motion.
Right.
It trains the first-year student to look for altered metabolism, restricted blood flow, and aberrant chemistry. Physiology is the difference between a living patient and a cadaver on an anatomy table, and our imaging paradigms should reflect that priority from day one.
I think the one area where we undoubtedly find convergence is that a first-year medical student cannot afford to ignore either side of this coin forever. They must eventually master all of the underlying physical principles, the radiation, the magnetism, the sound waves, and the radioisotopes.
Absolutely. A fully formed diagnostic intuition requires a profound fluency in both. You need the map, and you need to understand the traffic. But our respectful disagreement remains on which conceptual lens, static architecture versus dynamic function, should form the bedrock of their very first steps into clinical reasoning.
The complexity of visualizing the human body's internal environment is immense. When we think back to that clean, color-coded anatomy textbook from the beginning of our discussion, it becomes clear just how much of a simplification it really is. The body isn't an engineering schematic. It's a living, breathing mystery hidden beneath the skin. Navigating the interplay between structural fidelity and physiological insight isn't just a task to survive the first year of medical school. It is a lifelong intellectual journey for any clinician. We've laid out the theoretical foundations and the physics today, but how these imaging modalities are applied to specific, highly ambiguous clinical cases in the real world is where the true art of medicine begins. Next time you look at a medical scan, ask yourself, are you just looking at the map, or are you actually watching the traffic?